Good evening, everyone, and welcome. My name's Jeremy Pudney, and I'm the Director of Media and Communications here at Flinders University. And I'll be the MC for tonight's lecture and panel discussion, Rethinking Ageing in Australia. And I'm really happy to be here with you all, and it's great to see everybody has come along tonight. Before we begin, I'd like to acknowledge the traditional owners of the lands on which we meet this evening, the Kaurna people, and pay my respects to elders past and present. And I extend that respect to all Aboriginal and Torres Strait Islander peoples who are with us this evening. I'd also like to acknowledge that we have with us tonight Flinders University Chancellor, Mr. John Hood. Welcome, Chancellor. And Pro-Vice-Chancellor Research and Training and Capabilities, Professor Tim Cavanaro. Tim, thanks for coming along. And members of our Ageing Alliance Advisory Board and team, as well as many of our Flinders graduates and their guests. It's great to see you all here. You're very welcome. It's especially good, I think, to be here in the Flinders City campus. I'm hoping you won't be too distracted tonight by the astounding view. I just want to reiterate to everybody that the football doesn't start until this event has finished, so if you could please keep your eyes to the front, that would be excellent. But, you know, what's great, I think, about the Flinders City campus is that it's not only opened the door to so many students from different parts of Adelaide and South Australia and connected them with Flinders, but it also has really connected Flinders with our partners and industry and the business community here, and also people like yourselves, graduates and their friends and family, and it makes it a more accessible place, and it makes it possible to hold fantastic events like this one. So thanks again to everybody for joining us. A few quick housekeeping notes before we begin. Emergency exits, I think there's one, is located just over there in the back corner of the room. The amenities, which are an emergency exit of sorts, are also out that way and to your right. And I need to make you aware that this event is being recorded and will be shared afterwards. Tonight's event forms part of the Flinders University's Fearless Conversations series and is the first of 3 public events in the 2026 calendar connected to our Research That Matters initiative. And of course, ageing is something that touches every Australian, every family and every community. Yet we are living through a period of significant change in how we think about ageing, well-being, independence and care. And it feels like there are many challenges in this space right now and maybe not so many answers, or certainly some to discover. This evening we'll hear from one of Australia's leading experts in ageing research, Professor Maria Inacio, who is Academic Director of the Flinders Ageing Alliance and Director of the Registry of Senior Australians Research Centre. And she'll discuss with us the future of ageing in Australia. Thank you for coming along. After that, we'll be bringing together an outstanding panel. David Moran, CEO of Southern Cross Care. David, thank you. And also Patricia Sparrow, CEO of COTA Australia, and Brian Morden, a consumer representative with the Flinders Ageing Alliance. Thanks. So before we begin and hear from our keynote speaker, it's my pleasure to invite Pro-Vice-Chancellor Professor Tim Cavanaro to the stage to reflect on the importance of this topic and the role research can play in shaping a better future. Please join me in welcoming Tim now.
Great, thank you, Jeremy. It's an absolute pleasure to be here, and good evening, everyone. Welcome to Flinders University. It's wonderful to see so many people here with an interest in what is one of the most important societal issues facing Australia today. But before we go any further, I'd also like to acknowledge that we're meeting on the lands of the Kaurna people, pay my respects to elders past, present and emerging, and extend those respects to any Indigenous people who might be joining us here today. And it strikes me every time I come to this campus, what a fantastic place to look across these lands. It's such a privilege to be here. I'd also like to acknowledge the Chancellor, Mr. John Hood, members of our Ageing Alliance Advisory Board and the team, as well as many of our Flinders graduates and their guests who've joined us here this evening. As Australians are living longer than ever before, we're presented, I think, with what's a remarkable achievement, but what's also a very significant challenge. How do we ensure that longer lives are also healthier, more connected, more independent and more fulfilling? How do we build systems that support people not simply to live longer, but to age well? And these are the questions that really sit at the heart of this evening's conversation. And this event, as we've heard, is part of the Fearless Conversations series and forms the first of 3 public events this year, showcasing research that matters. Research that Matters reflects Flinders' commitment to tackling the challenges that have real impacts on people's lives, challenges that affect our communities, our economy, and our future. And that commitment really sits at the heart of our Agenda 2035 vision, which sets an ambitious goal of changing the lives of 10 million people. Achieving that goal requires us to focus on the issues that matter most to society and work alongside and in partnership with communities, industry, government, service providers together to create meaningful impact. These issues that matter to Australians, and ageing is unquestionably one of those very key issues. At Flinders, our researchers are working alongside government, industry, health providers, and most importantly, community to better understand ageing, improve care models, strengthen healthcare systems, and ensure people can maintain dignity, choice, and quality of life as they grow older. A major driver of this work is the Flinders University Ageing Alliance. The Alliance brings together expertise from across the university and our partners to address ageing from multiple perspectives: health, social participation, policy, workforce development, data, technology, and importantly, lived experience. And importantly, it recognises that ageing is not simply a health issue, it's a social, economic and community issue that requires collaboration across the sectors. One of the areas where Flinders continues to make a significant contribution is through world-leading research that helps inform evidence-based practice and policy. And that work will be front and centre tonight as we hear from our keynote speaker, Professor Maria Inacio. Professor Inacio is the Academic Director of the Flinders Ageing Alliance and Director of the Registry of Senior Australians Research Centre. Through the ROSA program, Maria and her colleagues have helped build one of Australia's most important sources of evidence on the experiences and outcomes of older Australians, informing policy and practice at the national level. Tonight, Maria will explore the future of ageing in Australia and the transition towards supporting more people to remain living independently in their homes and communities for longer. Following the keynote, she'll be joined by a panel bringing perspectives from aged care leadership, advocacy, and very importantly, lived experience. Together, they represent exactly the kind of collaboration that's required to address the complex challenges and create meaningful change that we need to undertake. So thank you for being here this evening and for contributing to what I'm sure will be a thoughtful and engaging discussion. So it's now my very great pleasure to introduce our keynote speaker. Please join me in welcoming Professor Maria Inacio.
Thank you so much for that introduction. I think you've done an amazing job introducing the Alliance and the Registry of Senior Australians. I would just take a little bit of time just to introduce myself. But first, I just want to thank you for your time and coming here today and letting me talk about my work. I'm always excited to talk about my work. I can talk about it all for a very long time, if you let me, but I'll try to stick to my 20 minutes here today. So I'm an epidemiologist by training. Epidemiologists study the trends of disease, the determinants of disease and their outcomes. But my focus has been health services research, so it really is the effect that health and aged care has on the health and well-being of older people. I personally also, I've been working on this field for 25 years now, but I have a lot of personal interest in this area. In the last couple of years, I've had personally to deal with a father who had dementia and ended up in a nursing home, so I lived through the experiences that I've heard others talking about throughout my career. I also have an older family member who recently has had 3 major health events and had to access rehab, leave the hospital, secure a GP consult, find home support at home. So all those experiences, again, that we've learned through our data, that I've been hearing about, analyzing, studying for a lot of my career, have become really front and center in my personal life. And I also want to acknowledge that I'm certain that most of you have also had those experiences. As Jeremy rightly points out, aging is one of those things that none of us can escape, and we're all experienced, and we all have cared for individuals that have experienced it. So I want to also acknowledge your experience in this area, also the experience of many of you in formally caring for people and delivering services to people, and encourage you to participate in our discussion later, because I'm sure you have also very critical experiences that we would love to hear from. Since I started my role in the Registry of Senior Australians, which also has been introduced, I'll just add that the registry was set up 10 years ago in response to the Oakden incident that happened in South Australia, which was really not a great experience here, where after the investigation, there was a bit of interest from the state government to support a project or an ongoing project that would monitor the quality and the safety of care that was delivered to people once they've entered the aged care sector. And that's where I came in and established the registry. So there is now 30 of us dedicated to studying older people once they've entered aged care services. We essentially integrate a lot of the national and state health and aged care data sets and a lot of other very key data sets that are related to people that are in aging from all sorts of sources nationally to understand those experiences from the minute somebody has an aged care eligibility assessment until they die. And you can just imagine how powerful it is to have that sort of information all in one spot and a team that's dedicated to analyzing that information together. We have 4 million people in this data set now because the information goes back to the early 2000s. So it allows us to essentially derive an enormous amount of information about these experiences of these individuals. But I'm going to take you back to 2017 when we started the registry. And at that time, most of the research that we did with the registry data, and I dare say a lot of the Australian research at that time, was focused on older people receiving long-term care in residential care settings. We didn't talk a whole lot about home care. I mean, home care was on the horizon. People talked about wanting to stay at home, but most of the research that we did and most of what was happening nationally was still focused in, I mean, half of the budget at that time was residential care, was spent on residential care. At that time, the home care package program that existed between 2013 and 2025 was only about 3 years old. And the Commonwealth Home and Support Program was just coming in and replacing the old home and community care program. There was about 1.3 million people receiving care at that time, nationally. And we talked a lot about home care replacing residential care eventually as the main source of support for older people, but it hadn't happened. But also in 2017, if you remember, there was the introduction of the consumer-directed care, so where older people got more rights and more ability to really dictate what they did with the support that they received. And the Productivity Commission also had released a report around that time that said that most older Australians prefer to age at home. And internationally, this is what was happening, but it wasn't happening here yet. It wasn't necessarily the focus. In 2018, the Royal Commission, towards the end of the year, the Royal Commission gets announced. And the very first thing they did was release an interim report in early 2019 saying that they needed to release more home care package for the people that were waiting for long-term care services at home. And since that has happened, we've seen the number of people receiving long-term care at home go from 72,000 in 2017 to 292,000 in June of last year. If you take a census like about one day, it's over 350,000 people in 1 year receiving long-term care at home. It's a fourfold increase in a very short period of time and how we've changed care for older people. Now, during that time, during the exact same period, the increase in people using residential care was only 16,000, like overall. It went from 180,000 daily users of residential care in 2017 to 196,000 in the last year's census. So the shift has happened now, and now we're a country that mostly delivers long-term care at home for people and not in residential care facilities. And the research hasn't caught up to it yet. Like, we're just now shifting into trying to understand these trends and trying to understand what it means. And part of the conversation I was having with Pat just a little bit before this is that we've talked a lot about access. We haven't talked about what happens afterwards. And this is the part where the research that we're doing now comes in. So my team has spent a little bit of time examining the experiences of older people receiving aged care services at home, both in our state and nationally now. At a population level, we have determined that there's quite a bit of different experiences of the people that are receiving home care, long-term care at home in compared to an aged care facility. And part of this, I mean, as you might expect, is because the people are different. There's some sort of selection that goes into who decides to do this or not. Part of it is because of other experiences. Part of it is the systems around them. But we have determined, for example, and I think this was surprising to all of us, that the people that were getting long-term care at home were actually more likely to be hospitalized for delirium dementia-related reasons. They were more likely to be hospitalized for weight loss and malnutrition-related reasons. And these are 2 times greater risks of these events happening. They were more likely to have medication-related adverse events. And the list goes on. Now, it is true that in a residential care facility, you have a lot of other support systems that prevent these things from happening, or they might deal with the exacerbation of these events in site and not necessarily send individuals to hospitals. But I do think that it is not optimal that individuals are receiving home care packages and are having such a high incidence of these events. We've also looked not just at specific types of hospitalizations, just to get a general sense of just how much time people are spending in hospital. And we found that when we looked at, and I'm not talking about small numbers here, I'm talking about hundreds of thousands of people, right? So I'm talking about 120,000 people receiving home care services and almost 200,000 people receiving residential care. We found that people accessing home care experienced more ED presentations in general, unplanned hospitalizations in general, potentially preventable hospitalizations in general. But more strikingly, I can go on about the list, more strikingly is that they spend 2.5 times more days in hospital than individuals in residential care. And we hear about people in residential care in hospitals all the time, but we aren't hearing about the people that are already in home care packages or now as support at home, and just the amount of time that they're spending in hospitals. So these numbers are a little bit old now. I think our analysis, we used 2019 data for this because of the tricky time of studying the years of COVID in 2021, and we're just now receiving more recent data. But you can imagine that these likely only got worse because now we have the 350,000 people accessing services yearly, as I mentioned. And we also know that during this time, and these are numbers not from my research, but from Stuart Brown's financial reporting of a large part of the sector, that people that were on the highest care level package of home support used to get 17 hours of care per week in 2010. And in 2022, they were reported to get only 8 hours. So, I mean, it's just less than half of what they used to get. On average, most recently, for the generic number of people, not just the high-level care needs, they used to get 8 hours, and now they're getting 4 hours. So you're also getting more people on services, but not necessarily more care. So lately, I've also been interested, because of all this work that we're finding, to try to identify, what is it that works? Because that's the next question, right? So how do you actually keep these people at home? So we took it upon ourselves to do this massive lit review, where we try to look at successful models of care, not just in the community and aged care sector, but also in the healthcare sector that helped older people to stay at home longer. And I'll go through the results now, but the idea was to identify models that essentially help people age well. Turns out aging well is a very complicated term. It can mean many things to many people. I'm sure within this room we can all disagree on many definitions, but we focused on models of care that showed scientific, robust evidence that they could actually help people spend more days at home, so less days in hospital and less days in institution, and delay entry into permanent residential care. So once we kind of got over the concept, we've looked at tens of articles and that provided some sort of evidence about models of care that help people stay home and not go to residential care. Now, the most consistent evidence that we found from this was not what we call, but they call complex multifactorial models of care. So what does that mean? It means that it's a bundled care package. It's something that includes everything starting from care planning to tailored care services that are for that individual. So that has the individual at a center with a very strong care planning element. But very importantly is that the most of the evidence also said that this care was delivered by a clinical workforce. So it's actually trained nurses, allied health professionals, and so on. A great example of this program we found is the Department of Veterans Affairs Community Nursing Program that exists here in Australia, which when compared to a similar age cohort of individuals that were receiving home care packages, on average kept individuals at home for 28 months compared to 14 months to the home care package recipients. The challenge with a lot of these complex multifactorial interventions is understanding what are the actual elements of them that actually contribute to the to this effect, because wouldn't it be nice if we had enough money as a nation, as a country, to do it all, right? To just throw everything at everybody. So we do need to understand what are the key elements that really do make a difference. And there has been a lot of research of people trying to nail it, what is actually the elements. And I would say that the two key things that they've identified are the care planning that I mentioned at the beginning, as well as medication reviews, which seem like very, actionable items to me. But I will leave it with the fact that it is very hard to untangle the effect of these actions from everything else on these models of care that we identified. There were some other models that had some good evidence of some other outcomes. Some of the models that I'll mention that had very good evidence of supporting people to stay home longer involve things like geriatricians, palliative care teams, and so on. But the problem with these models is we don't have the workforce to deliver them, and they're very costly. So that's another consideration of the reason why the uptake of them might actually be challenging, the actual large scaling of such things. Other models that are worth mentioning that we've also identified were things that we do have here in Australia. So the respite program is funded by the aged care program, and when used as intended, when individuals use it and go home, not as a try before you buy it, as is mostly used these days, it does reduce the likelihood of somebody entering residential care, and it does reduce the number of days they spend in care. We don't know if support at home or home care packages, as they were known up until the end of last year, do keep people at home. We actually don't have evidence of that. But what we do know is that even though I shared with you that the number of hours that people receive through those services has reduced, the number of days that people spend in those services over a similar time period has actually been has increased slightly every year. So there is probably some effect that these programs are delivering, which is good news. And finally, I will mention that social welfare support, while it's not a care model per se, it is critical for one's ability to continue to be able to access services and to do things that can keep them at home. And there is a lot of research that supports that. So in addition to the models that we've identified in this lit review and the analysis of the specific programs that my team has done, I should have mentioned that the respite program analysis was done by my team. We've done a lot of research around as well in my team around the role of primary care in supporting older people to remain at home, which is another really important component of facilitating somebody's health and well-being and independence and essentially general overall care. So we've looked at what is it about primary care, what are the elements of primary care that really make a strong contribution to somebody to remain at home and not be hospitalized all the time. And we actually found that it's not specific services, it's not somebody seeing their GP all the time, because older people, especially the ones that I'm talking about, they see their GPs all the time. They see them at least once every 2 weeks on average. So that's not what makes a difference. What makes a difference is the preventive trajectory of aged care, of primary care services that they get. That starts with, surprise, a health assessment, a chronic disease management plan, a medication review, allied health professionals, referrals. That trajectory has a very strong effect on their ability to remain at home. So it's proactive, preventive primary care services. The other thing that we actually found that makes a huge difference, especially for people with dementia, again, not a surprise, but a very strong effect, is continuity of care. So continuing to see their own GP. We had done research about the transition of continuity of care. So once somebody goes to a residential care facility, sometimes it's really hard to maintain your own GP. But when we looked at it in the community, we see the same effect. The ability to continue to see somebody you know makes an enormous difference. And there are obviously multiple reasons that we can, infer why that's the case. So In summary, the strongest evidence of models that help older people to live at home and stay at home longer and not in a hospital and not move to residential care facilities are those that have both a clinical and an aged care component. These multifactorial models of care that involve multidisciplinary, cross-sectoral providers, including primary care, are the ones that are most successful in supporting older people. The key message here is that to support older people to live at home is not the job of just one sector. The aged care sector alone cannot do it. Just get a home care package or just get a support at home program is not enough to maintain somebody at home. We need to have both the health, the aged care, and the social welfare sector working together to best attend to someone's needs. And this cross-setting shared responsibility is the only way that I can see as facilitating older people to remain at home for as long as they would like to. That's all I have for today. So thanks for your time.
Thanks to Professor Inacio. I think that was fascinating to listen to, and what I was thinking of when I was listening to you speak was the strategy that Flinders University has launched this year, which is Agenda 2035, Impact with Purpose, and the goal of changing 10 million lives for the better in 10 years. And I couldn't help but think how many lives that your work and your colleagues' work have already changed for the better. So thank you for that, and I'm sure that'll continue. And thanks for speaking here tonight. I'd like to invite our other panellists to the stage now, if we could, please. Great. I'm going to start with a question, if I could, to all of our panellists. We'll move our way along. But really what I'm interested to know from you all is your perspective on what ageing well means in Australia today and how that definition has changed in recent years.
Assuming that's on. From my perspective, it's being able to age with independence but support and dignity and relevance in our community, to be able to use our lived experience by contributing to our families as they go up and contributing to our wider community. So ageing well for me is not just about health, about who we are and what we can do and what it means to us.
Thank you.
Hi everyone, I'm Pat. I'm the CEO of CODA Australia, that's Council on the Ageing Australia. Useful for you to just know that we represent people over the age of 50. And sometimes audiences are a bit surprised that what we do is represent people over the age of 50 because they think that to be older means to be significantly older than 50. So I'm saying that in the rooms more often now, so I'm sure many of you could join up as supporters of CODA Australia, because the wonderful thing is that if we're lucky, we're all an older person waiting to happen, and some of us are closer to it than others. And when we talk about ageing well, I think we have to remember that we're all different people when we're younger, and we're all different people when we're older. We don't become a homogenous block where everything means the same to us. So ageing well does mean different things to different people. But the common things that people talk to us about really are things like having dignity and respect. And we do a report every 2 years called The State of the Older Nation, which is a representative sample of people over the age of 50. And there were two stats in that was released earlier this year that really stood out to me, which is that around 50% of older people don't feel valued by the community anymore. They don't feel that the community values them in any way, shape or form. And about 50% also said that they don't think government policies do anything to support them or acknowledge or take into account what their experiences might be. And that means for a lot of people they don't feel that they are ageing well. So it's important to have those stats because that is what people are talking about. But when you really dig down, people do talk about having dignity and respect, being respected in the community, having dignity, being seen as an individual, and being able to maintain their own autonomy. They're the common themes that people talk to us about.
Thanks, Pat. I'll have to join up. Good evening, everyone. David Moran, so I'm the CEO of Southern Cross Care, predominantly based in SA, but also do work in Northern Territory and Victoria. We tend to view ageing well through a kind of United Nations, there's a development goal number 3, which is around good health for all at all ages, and that kind of sets a tone for our organisation. So then we tend to look at the domains of wellbeing, which tend to be around your physical health, your psychological health, social health or social connections, and then obviously the environment. And for us as an organisation, we're trying to, how do we get all those things right and then measure quality of life? Because at the end of the day, it's about the quality of life of that individual person. So we tend to try and look at those 4 domains. And, you know, for us, we have this thing called Better for Life, which is our code for healthy ageing. And we measure that through quality of life indicators from the World Health Organisation. And when we do survey our residents and our clients regularly, because to us that's important. If that's tracking not well, then we're not doing our job. And so, and when you're looking at different cohorts of people in different environments, so whether they're people in their own homes, whether they're in retirement villages or residential aged care, all of those things contribute. Those 4 domains are really important to contribute to quality of life. So we believe as an organisation, if you're ageing well, then you're ticking those things off, because you need all of those things going for you to help to contribute to ageing well. So that's what we try to do as an organisation. So that's probably my answer to your question.
Thank you, David. Maria?
I can give you 2 answers. I can give the personal answer and then the academic answer. But the personal answer, I want to be productive for as long as I can and to be a contributing member of society. That's my version of aging well. But as I alluded to when we were doing the review on models of care that supported older people to age well, we found out there is absolutely no consensus academically to what it means to age well. And you could take a clinical view of it and you can say it's not developing frailty, it's not declining functionally, or you can take, a psychosocial well-being of it as being happy and being well-adjusted and feeling dignity and respect. There are so many different ways of looking at it, and I think all of them are valid and all of them are individuals and, are something that we need to invest on. That's why I think care planning is such a critical part of everything, because it needs to be targeted to the care that we deliver to older people needs to be targeted to the goals that they have.
Thank you. David, I've got a question for you specifically now, just around what the risks are. What are the biggest risks and the biggest opportunities in supporting Australians to stay at home longer as they age?
So I've made a few notes around this. So the big risks of obviously being at home for longer, and Maria's touched on them. Probably the big one for us is social isolation. The risk around social isolation is huge. Probably the costs as your needs increase and whether the system can cope with that. So as your frailty progresses at home or you start getting more complex, the costs of that care and the person being able to be sustained in their home when those supports are needed. The adequate assessment for higher levels of care, because we're really struggling with that as a sector at the moment, to actually get people assessed for higher levels of care and get that level of funding. And then the big one is remaining at home in itself is not ageing well. So that for us ticks off one box. That ticks off the environment because they're at a place where they want to be. But is that really ticking off the social connections, the meaningful engagement that people want? Is it ticking off their physical health or their psychological well-being, their mental health? So they're the things. So even if everyone wants to be at home, yes, good, that's ticked. That's just one aspect. That's not ageing well just by being able to stay at home. It's those other things, and Maria touches on a whole range of personal things. The opportunities, though, there are plenty. The big one that we see, we've been trying to promote this probably for the last decade, is around health promotion. So the ability for people, if you can promote good health for people living at home, they are going to be living better at home, or we call it better for life. And that means you'll have healthier communities, less hospitalisations, less in RAC. And I don't think the government quite get that yet in a home care environment. That they've got the system there, they're going to be funding allied and nursing, but society doesn't know that yet. And it should be better promoted because the system is gearing up for it. So I think that health promotion piece, and that takes a lot of work. So if you've got a home care client, convincing them to kind of do exercise or go to a gym is quite hard. So you've got to find out what's important to that person to actually motivate them to want to do that. And that's usually through goals-based prevention. So working out, okay, what does someone want? How can we actually do a lot more for you and actually meet a lot of your goals and be able to participate for as long as possible and be independent for as long as possible. So they're probably the big opportunities for us as a kind of an industry. So to be able to promote good health, to make home care work better. Because in the past it's probably been more around the low-level supports, bits of nursing going in. Just as an example, we've got a nurse-led home care model, but only 5% of our support at home get nursing, yet I've got 65% getting allied health. So we're promoting really well in that space, but we're still not seeing that level of acuity in the home yet or being able to get assessed correctly for it, so they either end up going to hospital or into a residential aged care. So that health promotion piece, which again stems out of United Nations, where they say health promotion, good health for all is a key ingredient to actually ageing well and having good health. So,
thank you. I just want to move on to independence and outcomes for ageing Australia and ageing Australians, and especially the word we've heard so many times already tonight, which is dignity. And if I could ask you, Pat, from the perspective of older Australians in your experience, what truly matters most to them in later life, and where is the system maybe falling a little bit short in that regard?
And look, I just, building on what David said, I think sometimes when we talk about aged care, we look at people as if they didn't exist somehow before aged care. They come in, we talk about the aged care system and what they need. So, I mean, some of the things that people really need is stable and secure housing. They need to have enough income to be able to live, to afford to pay for food and medication. And we see that people aren't always able to do that. Our State of the Older Nation research showed that 1 in 4 older Australians are living in poverty. So we actually need systems to work across for people to really have, what they need. But the independence and dignity piece is really important. And one of the good things that's changed with the new Aged Care Act that came in, that when we talk to older people that they would talk about, is that it's rights-based and it's focused on the older person. So the Act we had before 2025 focused very much on the relationship between providers and government. And what we now have is an Act that focuses on meeting the rights of older Australians. In terms of implementation, we're not there yet, but setting up an Act that has rights is actually going to help over time to actually really provide that independence, support people and to have dignity because of the change of the way that we're talking about the system. The system is falling short for people at the moment. If we look at aged care and particularly if we look at support at home, there have been a lot of implementation issues for older people. So older people are telling us they're not yet experiencing necessarily rights-based care. Some are, depending on their providers, but some are not. So where the system's falling short is now we've got a really good focus and outcome of what we want the system to deliver. What we need to do now is make sure that the reality there is for people, that they are able to get what people say is when we need services, we want to be able to get them quite quickly. People don't put their hand up until they really need support. So we need to be able to go into the system. We need to be able to get services quickly. We need to be able to get the services that we need to help us to stay independent. And that might be, as you're saying, David, it might be allied health, etc. And I think, physical health is really important. We need to do that work. But it might be that someone needs assistance with showering or they need assistance with, domestic chores. So they need to be able to get it quickly. We would say people shouldn't wait for more than 30 days. If any of you follow what's happening in the media, people are often waiting for a year to get the support they need. They need to be able to get what they want and need, and they need to be able to have adjustments made as they need it, and they need to be able to afford the care. So some people are finding the affordability of the new system difficult. So there are definitely gaps, but I think we've got great building blocks to go from. And older people, for the first time when we talk to them, are actually talking about rights and probably 18 months to 2 years ago, they wouldn't have been. They were referred to as recipients. It's passive, not that they can direct their care. So things are definitely moving in the right direction, but there are a number of things that we really need to make sure are working so that those shortcomings are addressed.
Thank you. I'd like to canvass this question with everybody on the panel if I could, and we've just heard that those delays, I mean, that must make maintaining your dignity and your independence really difficult. So if we're looking at care models that genuinely prioritise those things, dignity, choice and independence, how can we ensure that those models do that rather than focusing on convenience or cost? Maria, maybe if we could start with you.
Well, as I mentioned before, I think it's part of it is making it flexible enough and tailored and person-centered and with substantial, care planning that is, that really takes the individual and their preferences and their choices into consideration, because what is okay for me might not be okay for you. We talk quite a lot in our area about, and particularly around medication use and falls, and whether it's better to, at times, to sedate some individuals that might be having some issues because they are at risk of fall. But where we prefer them to be mobile, especially when they prefer to be mobile. So there's a lot of very tricky, very difficult situations, and I think it is about planning and tailored care for individuals, in my opinion. Yes.
For me, the approach must be more personal. It must be understanding of the individual, the circumstances that person lives in. We're all different. Some of us have got family, some haven't. Some live in permanent accommodation, others are more transient. Some are in the remote areas, regional areas and suburban areas. So the care and the delivery of that care has to be shaped to deliver a positive outcome for those individuals there. It also has to be connected. It has to be connected to the larger family where that's possible, or to the community where there is support for the individual. So from my perspective, it's really starting with the individual and then working out. Doctors, dentists are all important to us at our age. As Maria touched on earlier, a lot of the people that we are seeing, doctors and dentists, hearing aids, glasses, are all people that know us, that understand what our challenges are and are catering for us. But guess what? They're all starting to retire. And we're trying to have to find new people to come in. And that's a challenge. It is really a challenge. So if we can have a coordinated, across-the-board, person-centred approach, I think we would advance the quality of the life for the individual.
Well said, Brian, you're bang on. I did want to throw one other thing into the mix, though, which we see all the time that I think does sometimes get in the way of delivering person-centred care. That's ageism. So we do see it show up in all sorts of ways, in the way that in aged care sometimes workers will interact with older people in our communities. And older people and younger people alike experience ageism. Our research shows that, around 33% of people experience ageism in health settings, in aged care settings, in retail settings across the board. And I think it's important because your attitudes to yourself as you age and your attitudes to other people as you age, we often don't realise we're being ageist. And I do think it gets in the way of person-centred care. And just as an example, the Human Rights Commission does training on ageism, and they did some training in aged care. And the staff were originally like, well, we'll come along, but we don't really need training in ageism. We love older people. That's why we do what we do. They had an hour-and-a-half workshop, and at the end they went, oh, actually we are doing ageist things. We don't mean to, but we are. So one woman said, actually, I yell at everybody because I assume they can't hear me. So there are all sorts of examples like that, which sound small, but at their worst, what they do is they take away, we call it benevolent ageism, that we're trying to do the right thing for older people, but we often take away their agency and autonomy because we assume they can't make a decision. We assume we need to do something for them rather than finding out and meeting them where they are and supporting them to do it. So I think Brian summed it up really, really well. But one of the things that we're trying to tackle all the time now is the ageism that sits underneath that gets in the way of that. And the good news is that because we generally don't know that we're being ageist, when it's brought to our attention, we do want to try and address it. So I think it's something that we need to look at to really get to that person-centred care and relationship care that people are looking for.
Thank you, David.
Thanks, Pat. Brian well said. I've only got one thing, and I'm going to invent a new term because of what you've just said. I'll call it bureaucratic ageism. Because I don't know if you've ever had a parent coming into the aged care system and the difficulty navigating it and the forms, and I'm a CEO of an aged care organisation and struggle with it, and I work in it, right? So can you imagine how, if an older person that may not have family to support them do that, it is just ridiculous. And that, to me, and having to do more stuff online, it's just crazy. And so I think, you know, to have right care, right time, some of these bureaucratic barriers, and even as you move through the care trajectory and reassessments or having to get an assessment done because you need a walker or whatever, or pay a lot more money for it, there's things in there that do get in the way of right care, right time. Thank you.
Perhaps if we can consider lived experience and connection, or a lack of connection, it might be. If I could ask you, Brian, what does ageing look like, ageing at home look like in practice? And what do you think the realities are that are often overlooked in policy and maybe service design as well?
Yeah, thank you. Look, in preparation for tonight, I did make some notes, so excuse me if I start to refer to them because I want to try and remain on focus. And I think it's about context too. My lived experience will be different from other people's lived experience. So who am I? I'm 71. I've been retired for 11 years. My wife is of a similar age and she is a survivor of cancer. I have a 94-year-old mother who's living in residential care, and unfortunately I lost my father at 61 years of age, which has led me then to be the primary contact person and support for my mother. We have 4 children, 7 grandchildren, 1 great-grandchild and another one on the way. So I consider us to be an average suburban Adelaide older family. We enjoy great support from our children, and whilst accepting that, we've made it clear to them we want to remain as independent and supportive of each other, my wife and I, as we can. At our age, the pace of life and the changes in society are relentless. Technology, the impact and access and immediacy of information, our physical safety and our changes to social norms can at times be a bit overwhelming. Our ability to adapt and to keep pace is increasingly difficult. However, it's the physical changes that are the most challenging. Ageing is indiscriminate. It affects everyone who's lucky enough to continue to live. We've lived through an age where general awareness and focus upon health, lifestyle, research and innovation to improve the quality of life was not as great as what it is now. Life expectancy for our generation has improved, but I look at my mother and she's almost an exception to the rule at 94. We are living with that reality now. That's what we're facing. The loss of mobility and flexibility becomes ever more apparent. Simple jobs around the house become harder and eventually beyond our capacity. Morning and evening medications along with visits to the doctor become the norm. Our long-term, as I said, doctors and dentists are starting to retire. Modifications around the house are made to accommodate us. We start to make more hospital visits and attend more funerals than we do parties and weddings. We adjust our lifestyle. Lunch replaces dinner as a more attractive gathering with family and friends, and we certainly eat less, but we seem to keep more on. But it's not all doom and gloom. Our outlook is positive. We remain, as much as possible, engaged with our family, friends and community through common interests, sporting clubs, club memberships. We volunteer and we enjoy getting out and about. Independence, dignity and sense of contribution is important to us. Our aim is to continue to be relevant in our society. We look to the future. We look at our children's generation who are more aware of their health and fitness. They're more aware of the complexities and challenges of our world. Research is advancing and maturing policy and practical approaches to ageing are going to make their progress and their lived experience different to ours, hopefully in a positive sense. But when we consider what, and this is what I was asked to consider, is what might be done now, I look around me and I understand the number of professional people of a younger generation that have dedicated their profession to research and affecting policy and health decisions is such a positive thing. But in my view, the issue of isolation leading to a decline in mental health is an increasing problem for the older person of today. It's an area that would benefit from further research and definitely policy development. The development of the home aged care and support is a step in the right direction, but is not in and of itself able to improve and reduce isolation. In my experience, it's not unusual for a visit of a carer or the delivery of a meal to be the only contact an older individual will have in a daily average. Carefully designed and purpose-built technology leading to increased connectivity and community-led intervention is an area of research that could be explored, in my view. In addition to that, we need to understand and develop policy in regard to dental and optical health in the ageing population. Early intervention, ongoing maintenance of these two critical health issues is often forgotten because of competing physical health challenges. So it is positive. I don't mean, and I hope I haven't portrayed a negativity. We're enjoying the fruits of our life and we're enjoying the support of our children whilst also aspiring to be independent and a contributor. So,
Thanks, Brian, for your answer and also your personal insight. Thank you. So if we're looking at this shift and innovation and system change that needs to occur, if I could ask you, Maria, what needs to change at a system level? You know, is it policy, funding, workforce or infrastructure, or is it all of them, to better support this shift, this change?
Small question, yeah, a very small question. So,
sorry.
Look, from my research is into the quality and safety experiences that older people have while they're in aged care. And from the little that I shared with you today, the obvious things are that there are many more players outside of aged care that contribute to the experiences that people are having. So in my mind, the shared governance of these individuals is critical. That means that the fragmentation of the health, the social, the long-term care sectors is a barrier, because what's this person's problem is not my problem, so I'm not going to care because you do rehab, I do medicine, and the two don't have to deal with each other. And that's problematic in many, many ways. So the structural fragmentation that leads to the financial fragmentation, that leads to the clinical fragmentation of the systems, in my view, is the issue. So there are ways to have shared governance of patients. There are multidisciplinary care models, especially in health, around complex patients that have evidence that support people to go through journeys. Some of them are around diabetes management, some of them are around, now they're all going to escape me, stroke management after stroke. These things can exist in aged care as well. And I think that that's probably what I would like to see from a systems perspective, is more shared governance that comes from the attempt of shared responsibility and care integration. But I would be very curious to hear you guys' input on that as well.
I'm sorry, that was just a question for you. And in the interest of time, I'm going to have to police that. I apologise. What I'd like to do now is just provide the opportunity for a couple of questions from the floor, from people who've come along tonight, who may have had a question in their mind already or have had one pop up. We've probably got time for 2 or 3. We've got some people with roaming mics, so if you'd like to go first, thank you.
Thank you very much. It's been a very interesting conversation tonight, so thank you for that. My name's Christine Dennis. I have the privilege of actually being on governing boards for the acute sector, the disability sector and the aged sector. So I absolutely agree with you, Maria, that when we talk about system change, we actually don't talk about it as a system, as a complete system. We look at individual sectors and we try to change things within those sectors. So we've heard a couple of times tonight about the older person that ends up in the emergency department or goes into hospital. And so often the response is, well, we need more beds. So we need more beds in the acute sector and we need more beds in the aged sector. So my question is about how do we actually start to do exactly what you've said in terms of that cross-system collaboration? Do we have any mechanism, do we have any venues where we can come together and have those conversations? So that's the first question. The second question is that do you think the system is falling short for carers? Because it's very reliant also, not just on this home support packages and the hours that are available that, as you said, are shrinking, but the people that are actually the paid carers that are in fact aged Australians as well, that are probably heading towards needing a home support package themselves.
On carers, I don't think there's enough focus on what carers need. I don't think that's been a deliberate thing. I think just the way the system's operating now, we're not looking enough at carers, or we assume that if there's a carer there, then we may know, the system assumes maybe they don't need to put as much care in. So I think it is failing carers. And I think, I was having a conversation today with our policy committee about this and around silos, and got some really good advice today, really, about the fact that we have to look at breaking the silos at the framework level and at the delivery level, but that, we have to take that and work together to do that, because government silos are probably always going to exist. And that we won't be able to change that. So it's what can we do at a framework level when we talk, and what can we do at the delivery level, and some of that is in our hands. And I think that it really is about starting with the older person, or any person, because we need to look at these systems for people at different ages, and working across what that person needs is the only way we can probably really do it.
I will say there has been some progress towards the recognition. So the latest National Health Reform Agreement the addendum was released earlier in the year, which is essentially how public hospitals funding is delivered by the government, has recognized that primary care and acute care services are intimately, related in urgent care as well, and how they support each other. In this agreement now, there is more structure around the push and pull between the two. Aged care is not included in there. But with that being said, organizations like the Independent Health and Aged Care Pricing Authority, which I should say I'm a board member, is now, for example, responsible for doing the costing of both hospital care and aged care. So I think that there is an investment into having organizations that do have an understanding of both sectors, and that's probably the beginning. The Productivity Commission in the end of last year also released another very beautiful report. I'm a big fan of their reports. And it talked a lot about systems efficiencies and care integration, where there are new frameworks for understanding the cross-sectoral governance of the workforce, some systems management. So there are some progress in that area. And I think the fact that we are starting to talk about it more, some activity is happening. The portfolio on the Prime Minister's cabinet under the care economy has aged care, health care, child care, so it is being talked about it together now a little bit more, even though the operations is still, the implementation is still very separate. I think there is more of the governance being discussed, and I think more of that needs to happen.
Thank you. Did you have
Could
something?
Could I also add that at what Rosa and what the Alliance are doing is engaging with that grassroots, the older person. They're encouraging them to come along at an early stage of research and during the body of the research, and importantly in translating the outcome of the research into a practical outcome. And in my experience, that can never be underestimated. We're the people living through this experience, and so therefore for us to be able to engage is a very big step forward to what you're talking about, is how do we get a broader understanding and then get a practical outcome. So I applaud both the Flinders Uni and the Rosa for inviting us along and engaging with us.
Thank you. We've probably got time only for one more, I'm afraid. Yeah, perhaps you, sir.
My question would be, who does it at home care the best in the world? Who does it? What has research said that?
It's funny you should mention that, because I just came back for the International Association of Geriatrics and Gerontology Society meeting in Amsterdam last week, where there were people from all countries going there talking about their different models of long-term care delivery. We all have problems, like we all have issues, right? But there are some that show it as being a lot, I guess, that have a much more positive feeling towards their programs, even though they have problems. And interesting enough, I guess, in my perspective from hearing them talk, was something about divesting of centralized units into more of local government areas, where the communities themselves were the ones that focus in delivering the care. So the councils of different organizations, and this is true in the Netherlands, this is true in a lot of the Scandinavian countries, they're the ones responsible for the care, is not a central thing. My understanding is that that's how it used to be here in Australia many years ago, and things have shifted now, many, many decades ago.
Yeah, the one I love, and it probably isn't home care, but is Singapore. And it's very easy because it's one level of government, but that's more at the prevention end. And I think Australia needs to do a lot of work, because we're swamped now, but the wave coming's a lot bigger. And so the work around the 50 pluses, are your members supposedly, that's where the work needs to start, because we need them to stop coming into the system. They need to be healthier. And so if you look at Singapore and what they're doing with their age group, they actually incentivise people to go to wellness centres. So they're getting social engagement, they're getting exercise, and they're staying healthier because they can't have them going into residential care.
That makes a lot of sense.
Yeah, and that's as an organisation, that's what we aim to do as an organisation. But it's very hard to do that in Australia. But capturing it up front and preventing the acuity kicking in, and you can do that. We've proven it. There's enough operators that have proven you can do it. And when you go to Singapore, they've got an SG65 app, so you get rewarded for going to these centres. So you get kind of free bus trips and shopping vouchers and all of that. So there's things there that the government could look at down, because they need to prevent people coming in. They need the population, the 55 pluses, to be healthier for longer and kind of blow that curve out of frailty, decline into frailty. And that's the answer in a nutshell, and the system needs to do it.
Thank you. Now, at the risk of getting into trouble, I'm going to take one more. I think I overlooked... yep, go. Thank you.
It's actually the exact comment. I had a comment and not a question. And so I'd just like to reiterate, as the Active Ageing Project Officer for the City of Unley, how critical it is that at that local community level we need to support the 50 plus and all ages to stay out of that very grim sounding system. I don't think anyone here in this audience wants to have to face that, and we have a responsibility ourselves to stay independent and do what we can to age well at all ages.
And by the way, frailty you can reverse, and we've shown it. You can actually reverse frailty, and you can certainly delay it.
Can I just respond to that
Yes.
really quick? Is that all right? I was just going to mention that, we did focus on a lot of negative aspects of the sectors, and I feel a bit guilty now because of what you said. We do a lot of evaluation of performance within the sector, and I will say there are exceptional providers nationally. There are people that are thriving, doing well, that operate at the numbers that you hear people talking about, antipsychotic use, falls, ED presentations, all these things. There are providers that have a fraction of the incidence of those events, and they are all around us, and there's a lot of them. So it's not all doom and gloom. There are very, very good providers around, and yeah, I just want to.
Thanks, Maria. I was just going to add to that because it is true, and what we do often find is that it might be hard for people to get onto the system, but once they're actually in and they've got a good provider, they're generally fairly satisfied with the services that they receive. So we did focus today more on challenges and issues, but there are some good things happening, and older people report that as well.
Yeah, I think that's a great point. Thank you very much. I won't take any more questions now, I'm sorry, but I'm glad that there were so many people who had thoughts or questions inspired by the session, but I'm not surprised by that because it's been outstanding, I think. I'd like to ask you to join me in thanking our panellists, Maria, David, Patricia and Brian. I think they're owed thanks not just for the insight and the thoughts that they've shared with us this evening, but for the work and the advocacy. So we're very grateful. Thank you very much, and we're grateful for your time. I'll skip over some of my closing remarks because I allowed too many questions, but I do want to point out to you before you leave, ask you to take a look at the materials that have been left on the chairs there this evening, and scan the QR codes if you could to learn more about the work taking place here at Flinders University, and take a look at the Flinders website for upcoming Fearless conversations that we'll be having later this year. And most importantly, reach out. Real change happens when researchers, practitioners, policy makers and communities work together. And if tonight's discussion has resonated with you, we'd welcome the opportunity to continue the conversation and explore how we can all work together to make a difference. So thanks to our guests. Thank you all for coming. I hope you found it as beneficial as I did, and enjoy the rest of your evening. Good night.